Hi, so let's talk about SIADH and DI. So let's get started. Let me find my little arrow. It helps if I can see. Here we go. So first of all, when you're talking about SIADH and you're talking about DI, one of the things, the trigger is ADH, and ADH is antidiuretic hormone. And this plays a huge role in both of these disease processes or disorders, which is SIADH and DI. So ADH is produced in the hypothalamus. You have your thalamus, and then your hypothalamus, and then you have your posterior pituitary gland. You have your pituitary gland, and it splits, but it's the posterior pituitary gland that will secrete and store your ADH. So your ADH is produced in that hypothalamus, and that posterior pituitary gland is what secrete or stores the ADH. So it's good to kind of know where in the brain that this is going on. And that gland sits at the base of the brain. So that's what we're looking at. What does ADH do? Well, it does some big time stuff. It keeps water in the body. It wants to actually deal with the renal tubules. It'll cause the renal tubules to keep water. So they'll dilate, want to hold on to water and keep water inside the body. It also constricts blood vessels. ADH is also known as vasopressin. So I just want you to understand that. So just think about that. Pressin, if it's pressing, it's going to constrict, right? Just food for thought. Okay, SIADH is syndrome of inappropriate antidiuretic hormone secretions. Big stuff. So we say SIADH, just makes life so much more simple. So the things that you need to think about is fluids on the inside, right? We're holding on to fluids. So we're going to have an increase with this with ADH. We're increasing our ADH. And when we do this, we're going to stop urinating. So we're trying to hold on to fluid by producing more. We have this increase in ADH. And we're going to have a higher specific gravity of urine. We're going to be greater than 1.030. If we stop urinating, then our urine is going to become thick and dark. It isn't good. We're not urinating. So we're kind of holding on, and the little bit that comes out is not clear, yellow, healthy urine. And so we're going to have hypoosmolality. So we're going to be thicker, sticky, yucky urine. Okay. So we're also going to be hyponatremic. Now this gets kind of tricky for people, because what happens is you're thinking, how, if I have all this fluid, and I'm not urinating out, what's going on? Well, we're going to hold on to fluid. And because the sodium level is not changing in our body, but we're adding more fluid to it, it's going to dilute the sodium. I always like to think about Kool-Aid, cherry Kool-Aid. You either make it, pour your packet in, and you do a little less water and how dark and thick it looks, or do you dilute it too much and fill it to the rim of the pitcher so that you get tons of Kool-Aid or that extra glass in there? And because of that, then we're going to dilute it, right? It's the same amount of Kool-Aid packet and sugar that we put in it. But if we have less fluid in it, it's going to actually concentrate it. And if we put too much fluid in it, we're going to dilute it. So with SIADH, we're diluting that sodium within the body. And that's why we become hyponatremic. We're going to have headaches, and they can become severe. That is an early sign of SIADH, this headache that just doesn't go away, it gets worse. And it can lead to then seizures. We're going to have super hypertension, severe hypertension. And with these things, it's going to cause the headache to be even worse. The nursings do stop all fluids. Do we need to give someone that is full of fluids, more fluid? No, we need to stop fluids unless we are having to give 3% normal saline, which is a hypertonic solution. We also want to encourage the client or patient to eat salt, because by doing so, then we're going to hopefully pull some fluids. We're going to see edema, and we're going to be tachycardic because of all the fluid overload internally. Our heart's going to be beating faster, trying to keep up with this volume status. SIADH causes lung cancer, small cell carcinomas. This lung cancer is one of the, is a disease that we normally can see SIADH. And it's kind of tricky because who would have ever thought, right? It causes ADH to be overproduced. We have receptors throughout the renals, the lungs. And so when we get this lung cancer, it can create us and cause us to overproduce ADH. So we're going to have an increase in ADH, and that's what causes SIADH. Trauma, if we have anything that's going to squeeze that pituitary or cause damage to the brain that will increase ICP, anything like that, we can have a increase in ADH, and that is going to cause SIADH. Surgeries, sepsis, meningitis, these are all causes. Notice these are things that affect our brain, right? Because we are actually affecting that posterior pituitary gland, and that can cause this overproduction of ADH. Okay. Let's talk about DI. DI is diabetes insipidus. We're going to have a decrease in ADH. We're going to diurese, right? The D's. We're going to Dollywood. I'd be so excited. We're going to diurese. We can diurese up to 24 liters in a day. It's mass quantities of volume. They're urinating or peeing this out, and it's clear. It's clear, and it has a low specific gravity. It is less than 1.005. It's diluted urine. So our SIADH urine is sticky, yucky, thicky, dark in color urine. Our DI urine is clear water, diluted urine with a low specific gravity of less than 1.005. We're going to have an increased thirst, and these patients or clients are going to want to eat tons of ice or drink tons of fluids. They're trying to correct what's going on. They're thirsty because they're dry. They're urinating out. But the problem is with this situation, they can't hydrate because they're just losing too much urine too quickly. We have to fix the problem to fix that thirst, to be able to quench the thirst. They're going to have a dry mucosa and dry skin because they're dehydrated. They look dehydrated. They are just losing volume massively. They're going to be hypotensive because we have a loss of volume. We're going to give desmopressin, DI, desmopressin, another D here. This is going to decrease the urinary output and increase the blood pressure. So if we have a decrease in ADH and I give desmopressin, I am giving a synthetic form of ADH is what I'm doing. And this is going to then cause that decrease urinary output. It's going to make the renal tubules dilate and want to hold on to fluid. And it's going to constrict vessels, and that's going to increase our blood pressure. We want to watch for hyponatremia, because what can happen is we can have a DI patient that's mass urinating, right? Just mass volumes of urine. And we give the drug to increase our ADH, and it's a synthetic ADH. So we're giving it to them so that we decrease the urinary output and increase our blood pressure. And by doing that, we can flip it. So we've got to be very careful when we're giving desmopressin. We want to definitely watch our patients for hyponatremia. signs and symptoms. They're going to be hypernatremic because we're going to lose mass quantities of fluid, but our sodium levels don't change. So if that's the case, back to my Kool-Aid analogy, if you're looking at a packet of Kool-Aid and you pour it in your pitcher and you put your sugar, same amount in your pitcher, if I am going to lose volume, if I have loss of volume in that pitcher, it's going to concentrate, right? It's concentrating what's in there. And so because of that, I'm going to have a high concentration of sodium. Just like in the Kool-Aid, I'm going to have a higher concentration of the Kool-Aid crystals and the sugar because I'm going to have less volume. I hope that makes sense. So if I put my Kool-Aid in, put my sugar in and fill it to the rim with water, I'm diluting it. And by diluting it, I'm in SIADH because I'm holding on to the water. I'm full of all this fluid. If I don't put as much water in the Kool-Aid pitcher and I look at my glass, it's going to be darker. You're not going to be able to see through the Kool-Aid, right? It's highly concentrated because it's the same in there, but with less volume. And then we're going to have a weight loss. So that's why we're either going to be weight gain or weight loss. For DI, weight loss, we're getting rid of volume. Okay. For SIADH, nursing interventions and things we want to look at and do is we want to do daily weights. Honestly, we'll do daily weights for both. And we'll talk about the other here in just a minute. And we want to, not weekly weights, daily weights. Ding, ding, ding. Just remember that. And know with daily weights, what do? Same time, same scale, same clothing. You know, best to do when we get up in the morning, go to the restroom, and then get on the scale, daily weights, and track them. Make sure if you're educating your client or patient that you tell them to write it down. They're not going to remember. They need to write things down. So Monday, this is my weight at what time? Tuesday, this is my weight at what time? And just have them track it so that when they come back to the doctor, if they need to, it's there for them. If they're home dealing, they would be probably in a hospital with SIADH being treated, but just in daily weights in general, you want them to track it. For SIADH, this is life-threatening and can be. So they'll be in an ICU most likely. So those daily weights are, you have the bed, right? Back to your basic nursing. We have our bed. When we do zero out the bed weight on the bed scale, we have what? 1 or 2 pillows, depending, whatever we do. A sheet, your pad, blanket, that's it, right? The basic. Get rid of the 5 other pillows, the 4 other blankets, because that's gonna alter the weight. And then you weigh your patient. So it's very important, daily weights, and to document those weights. Fluid restrictions with SIADH. If I am volume overloaded, if I'm fluid overloaded, like a big giant ball of water, do I want to have more fluid, drink more? No, fluid restrictions. And I'm going to go ahead and say strict fluid restrictions, meaning you don't carry the water pitcher in to give them something to drink. You're going to measure every bit that goes in and every bit that goes out. Okay. Seizure precautions, right? They can have seizures, so we need to be very careful. Strict INOs, we're going to watch that, document. Feed them salt. They need salt, right? Because they're diluted, they're hyponatremic. We want to give them a little bit of salt. And what happens by feeding them salt, it's going to help shift fluid, maybe hopefully diurese. Also, loop diuretics, not always prescribed, but we also know what they do. They're going to help pull fluid off, hopefully, and get rid of some fluid. Just remember with your loop diuretics, they're potassium wasters. So we want to make sure that we watch for hypokalemia. Okay. And then hypertonic fluids, we're going to probably give them, they're hyponatremic. So they're low on sodium and we need less than 135. So we want to give them hypertonic fluids, which remember hypertonic fluids are your 3%, 5%. It's usually 3% normal saline, but you can have 3%, 5%. Remember the whole little rules of 3, 5s, 10s. Okay. So that is hypertonic fluids. We'll want to give them. Also, we can give them declamycin, and I'm not sure if I spelled that correctly. If it's misspelled, I apologize. It's like 2 in the morning. This is tetracycline, so do not give it with calcium, milk products, or antacids. It's going to affect, and I stopped, the absorption. It affects absorption, so we have to be very careful not to, when we're educating our client or patient, not to take this with a calcium, milk products, or antacids. Okay. This medication, declamycin, is going to inhibit ADH, and it's going to promote diuresis. So it's actually a very good medication to give for SIADH. DI, what are we going to do? Daily weights again. We just discussed it. I won't say it again, but we need to make sure daily weights, strict I's and O's, safety. We need to watch safety with these patients, both SIADH and DI, because we are going to have the potential to have seizures with SIADH. For DI, we can get it. We're getting up, going to the restroom all the time. It can be, people can become confused with the hyper or hyponatremia. So it's just safety issues, and we need to think about safety. If they're having to go to the restroom all the time, to the bathroom every time, bed needs to be in low position. If they're able to get up, the rail needs to be down so they're not climbing over the rail. We can also, most likely the doctor could prescribe desmopressin. It is to actually increase the ADH, because we have a decrease in ADH with DI, DD, right? So you want to watch for hyponatremia. We can flip patients if we're not careful. We have to be very careful. So we want to watch this. And then one of the things I want to say to you, because as a nursing student and a new nurse, and even an older nurse, before I really thought about it, you think diabetes insipidus, diabetes mellitus, you think it's in this family together, but they're not related. So don't connect it. DI is something very different than diabetes mellitus, which deals with your blood sugars. That is all for me for SIADH and DI. This kind of breaks it down so that it gives you an understanding. And then knowing the things that I'm saying, like what you're going to do as a nurse, what you want to look for as a nurse, I want to make sure that you understand that, because that is how you will answer questions, or that is how you are going to connect or relate to your client or patient and provide safe nursing care. So I hope this helps, explains a little bit about it, and go back to your readings. And if you're still confused, for my students, please reach out to me. I hope you have a wonderful evening.